This is getting ridiculous. Let's talk about research on keto for mental health. Hello, I'm Dr. Sam, this is Dr. Sam's Health, and today I would like to continue reviewing different diets. I made quite a few videos about ketogenic diet. Myself, I cannot say that I'm a big proponent of specifically ketogenic diets, but I'm in general a big proponent of lower carbohydrate diets. And I've made quite a few videos about keto, and at this point I was thinking about making some videos about ketogenic diet for mental health, just because I'm a psychiatrist and it's a very interesting aspect of keto diets and people who are promoting ketogenic diet, because they always talk about some keto clarity, improvement in mental health, and so on. And just recently there was an article that was published on ketogenic diet. Specifically, they used ketogenic diet in patients with schizophrenia and bipolar disorder. And this article definitely drew my attention for a variety of reasons, and I would like to review it today. Before we proceed, I would like to make my regular disclaimers and some extra disclaimers today. First of all, I'm a medical doctor, but I do not provide any kind of medical advice over YouTube, over internet in general. Everything I talk about is purely my opinion. These videos are made for educational purposes, sometimes for entertainment purposes, but my opinions that I present here do not necessarily represent the opinions of my regulatory bodies, my universities, my colleges, my discipline, psychiatry, and so on. And one more disclaimer specific for this video. I'm going to provide you with very quick critical appraisal of a research piece here, and by its nature it will be very critical. And I don't want to sound critical, I don't want to sound negative, but this article, it did hit home in my case because I'm a psychiatrist and I'm a scientist and I know how clinical trials should be properly organized and run, how to report clinical trial results. And unfortunately, this article has quite a few deficiencies, to say the least. And I actually tried to make a video on this article a couple of weeks ago, and it took me like 2-3 hours to record all my observations and concerns, and when I started editing it, it turned out to be an hour-long, very negative piece, and I don't want it to be such. First of all, I don't want to sound negative, I don't want it to be very long, but at the same time, this article hit home, and I really feel that I should make a video about this article. And the main purpose of this video is not to criticize, but rather to caution, to warn people that sometimes when you are not properly equipped to understand clinical research data, the results might be misinterpreted and might become a tool of essentially misinformation. And that is something I'm trying to avoid, obviously on my channel, but in general, I hope that my work will help you go through research and understand it properly. So without further ado, let's get to the article. So I've got this article here, I printed it. I believe that this article is in public access, so I'll add a link to it to the video description for this video, and you can check it out yourself and make your own conclusions. The article is titled Ketogenic Diet Intervention on Metabolic and Psychiatric Health in Bipolar and Schizophrenia, a Pilot Trial. From the get-go, I must say that as a psychiatrist, I'm a little bit annoyed with the word bipolar here, just because the proper term is bipolar disorder or bipolar affective disorder, and I find it to be like borderline unprofessional to publish in psychiatry research an article with the term bipolar instead of bipolar disorder, which is already, technically it's wrong. You know, we shouldn't be using this kind of terminology in professional publications. There are multiple other things throughout the article that I really don't want to dwell on. Like, for example, they write down DSM-5 with 5 as a Roman V, Roman numeral, which is incorrect. Initially, the authors, the creators of DSM-5, they actually specifically said that they are changing their approach so significantly that they would like to actually indicate it even in the title of DSM-5, and they switch from Roman numerals to Arabic numerals, so DSM-5 should be spelled like that. There are lots of little things. I really don't want to dwell on them too much because we've got much bigger issues in the article, and the main principal issue that pretty much invalidates everything that they do. So let's talk about that. All the major issues obviously are rooted in the study design, and I think I have to say a couple of words about the study design. It is a single-arm study, which is the huge issue. It is a principal concern of mine. And what they have done, they have taken 23 subjects, participants with different psychiatric conditions, bipolar disorder and schizophrenia, and they have placed them on a ketogenic diet protocol, monitored them for 4 months, and reported an overall improvement in their mental health, essentially. So, the issues that I have here, first of all, sample size. Sample size of 23 subjects. They actually report the data on 23 subjects, but 2 of them dropped out, and 1 of them dropped out for the most ridiculous reason for this kind of research, which was the person turned out to be vegetarian, and they couldn't stick to ketogenic diet protocol because most of the food items were not catering for vegetarians. The reason why I'm saying it's ridiculous is just because how do you enroll participants? How do you get informed consent when you are explaining to the subjects that the study entails this, and that, it will be ketogenic diet, so mostly it will be animal-based foods, or significant portion of your nutrition will be animal-based, and you somehow enroll somebody who is vegetarian, and then they inevitably drop out, right? So that's one thing that just shows that the whole design, preparation, and conduct of the study was somewhat sloppy. The second thing is the size of the sample. 23, 21 patients is not adequate for pretty much any kind of good statistics. We have statistical tools, multiple tools, and they all imply certain things like normal distribution or approximation of normal distribution, which usually happens with sample sizes that are 30 and above, and the higher the sample size, the closer it is to normal distribution, and it makes all analysis smoother and applicable. When we are dealing with sample sizes of less than 30, usually we have to use certain variations of standard statistical tests, and I don't think the authors did it. So that's another flaw. And also, the reason why I'm talking about it is I'm actually a little bit surprised that they conducted a nationwide search for participants and could only find 23 participants. These people are well-established clinicians, researchers. They belong to big institutions like Stanford, for example. And as a psychiatrist, as a practicing psychiatrist, I can tell you that any psychiatrist at any time of the day, month, year, whatever, can find you 30 plus participants with bipolar disorder and schizophrenia in their practice just on demand. And I'm surprised that such a great group of researchers, backed by such great institutions, conducting a nationwide study couldn't find sufficient amount of participants. The next thing is the distribution of diagnosis or clinical conditions that we're working with. So they have included patients with schizophrenia. Some of them actually turned out to have schizoaffective disorder, which is a schizophrenia spectrum disorder, but it is distinctly different from schizophrenia. There were just 5 participants labeled as people with schizophrenia. There were 16 participants at the end of the day, the ones who stayed in the study, who had bipolar disorder. And bipolar disorder is also a very heterogeneous cohort of disorders, or group of disorders. So there is bipolar 1, bipolar 2. Most of them had bipolar 2. But also within bipolar disorder, there are phases or episodes of depression and episodes of mania and hypomania. So you can see that this whole small cohort of patients can be broken down into small groups of like 5-3 people, which is not a good distribution for conducting any kind of analysis, because the group is very heterogeneous. They're like absolutely different patients, and they are trying to compare certain things across the board. So, for example, if we're talking about severity of depressive symptoms, which is one of their main outcomes, we can have somebody with schizophrenia, and people with schizophrenia, they do get depressed. We actually have a special depression scale for people with schizophrenia. It's called Calgary Depression Scale, and they're not using it. They're using just a very basic PHQ-9 test. People with schizophrenia are actually known to have emotional deficits, and it's actually very difficult to measure depression in people with schizophrenia. Sometimes we don't know whether it's depression or emotional flatness due to negative symptoms of schizophrenia. Then we get bipolar disorder, and some people would be depressed, some people would be in mania or hypomania when the depression scale is not really working. You cannot get good results on depression scale in somebody who is in the condition that is essentially opposite to depression. So that brings me to the next issue, which is the choice of clinical tools. For example, for depression, they use PHQ-9, which is a very basic screening, essentially, tool for depression that usually like family doctors use in their practice. And I think that for somebody who's doing this kind of research, you need to have something more robust, like back depression inventory or quiz, or there are quite a few scales actually. They are much better in my opinion than PHQ-9. And another scale, for example, that they use is BPRS, which is brief psychiatric rating scale that is used for assessment of severity of symptoms of schizophrenia, let's put it this way. And they have 5 participants with schizophrenia. They're using this scale for everybody. They do report the outcomes of this scale in the abstract, but for some reason they do not report it in the summary table. So I've got quite a few questions about like why this article and research study in general were organized the way they were organized. And if we didn't have the bigger problem here, I would definitely could talk for hours about the issues with the study design. But again, we've got much bigger issue at hand, which is single arm study. So what am I getting at? I'm trying to say that this study, being a single arm study, cannot even possibly show that ketogenic diet improves anything. What I mean by that is that this study doesn't have a control group. So what they're doing essentially, they're taking a group of people who are relatively clinically stable. They do have schizophrenia, they have bipolar disorder. Both conditions are known to be chronic conditions, but they are taking people who are relatively stable because otherwise they wouldn't be able to get all these measures done. They wouldn't be able to get informed consent in some cases. So these people are enrolling into this study, receiving treatment as usual, essentially. They all are receiving medications, psychotherapy. They also get much more attention because they are part of the study. And also on top of that, they are adding the ketogenic diet component. We do not know whether these people would not improve without ketogenic diet. Quite frankly, based on everything that I've seen in this article, I can tell you that the outcomes of this intervention are quite similar to what we see in regular clinical practice. As a psychiatrist, I have treated a lot of people with schizophrenia and bipolar disorder, all phases and forms, and I can tell you with a proper standard clinical approach, over the course of 4 months, majority of people will improve, if not achieve remission, both with schizophrenia and bipolar disorder. Moreover, the mere fact of participation in clinical trial and getting extra amount of clinical attention, all the measures that they are using in the clinical trial, they have a tendency to have some sort of a therapeutic effect. Just to give you a couple of examples, people who are participating in clinical trials of depression tend to improve, and usually they run some sort of a placebo-controlled clinical trials, and usually what is reported is that there is a significant improvement, and this significant improvement is statistically significantly different from placebo. But if you look at the outcomes of all these participants, usually people who are on placebo, they also notice significant amount of improvement just because they are participating in a clinical trial. Also, there are quite a few studies that show that the use of measurement-based care, meaning using clinical tools to measure patients' progress and incorporating the results of this outcomes or tools into clinical care, using it to steer the pharmacotherapy, psychotherapy, usually has very beneficial effects. There are quite a few studies that are objectively showing much higher level of improvement when this kind of tools are used. And again, what we have here is a group of people who are receiving treatment as usual, plus extra attention from clinical trial, plus the use of measurement-based care, essentially. So I'm not surprised that they've got good results overall. They are not exceeding expectations of a typical psychiatrist with their clinical population. So I don't find anything sensationalist here. And one more time, what I will say is that without having a control group, we will never ever know, and we cannot make any kind of hard conclusions about ketogenic diet being effective tool to ameliorate psychiatric conditions. At this point, I would like to stop and to say that there is a critical mass of deficiencies and flaws in this study that pretty much invalidate all the findings of this study. And quite frankly, I'm surprised that people with amazing credentials and affiliated with amazing institutions couldn't run a better study. I've got quite a few thoughts about why exactly they've done what they have done, but I don't want to be speculative here. I don't want to make any kind of conspiracy theories and so on. I think that what is safe to say is that the study is a pilot trial, and I just hope that in the future the researchers will actually be able to use the information from this study to actually pave the way for properly designed research project with more homogeneous participants, with larger sample size, and with a control group, which is incredibly important. At this point, this study is essentially invalid. The only positive aspect of this study is that the researchers can actually say that, we have tested the ketogenic diet on very complex clinical population, and only 2 people dropped out, and overall there was some improvement in their mental health, and they can use this data to actually guide the more robust further research. And I honestly hope that some sort of this kind of research will be done in the next year or 2, and actually I wouldn't be surprised if the authors actually had this in mind when they were implementing this study. And just before I wrap up, I would like to make one point. One of the main reasons why I wanted to make this video is I am afraid that the results of this study will be misrepresented in social media. Quite frankly, I've already seen quite a few posts and people talking about this study and pretty much saying that this study clearly showed that ketogenic diet improves mental health in patients with schizophrenia and bipolar disorder. Again and again and again, this kind of research cannot possibly, on principle, scientific level, back up this kind of claims. You need a comparator. You need a control group. You can use any kind of other diet. You can use general nutritional guidelines. You can use, I don't know, the rational diet as a comparator, though I'm afraid it will be relatively close to keto at the end of the day. But my point again is that I'm afraid that people will misinterpret and misrepresent the outcomes of this clinical trial, and that will lead to further confusion. And the main reason why I'm making these videos is I just want to dispel the myth and to make sure that when you are coming across this kind of studies, you know how to interpret them and know what actual findings and conclusions can possibly be and what they are. And that's it for today. Thank you so much for watching. If you like this kind of videos, hit the like button, subscribe, hit the notification bell, maybe leave a comment, ask me questions. Maybe you got some interesting thoughts that you would like me to work on. So any kind of dialogue and interactions are always welcome, and I'm looking forward to making more videos on keto. Thank you so much and have a wonderful day. I'll see you soon.